Sir, very good morning, sir.
Good morning. Good morning.
So good to go. Can we start? I'll just ask my technical team whether the session is live.
Yeah, sure. We can start.
Technical team, is the session live? Can we start?
By 10:30, sir.
Huh?
They'll be live exactly by 10:30, so.
10:30. Okay. So another 2 minutes to go.
Okay.
Sure.
Yeah, thank you. So once you're done with the slide, just say next. I will proceed to the next slide.
Okay.
Yeah, so we are live, sir.
Yeah. Chalo, we can start, sir, with your permission.
Yeah, sure. Thank you. Good morning, everybody. Today's topic is optimizing tighter control with end organ protection in management of hypertension, the role of ARB plus CCB. Next slide. Hypertension prevalence, recent ICMR data is in India is about 35.5%. Predominantly, it is more in the urban areas as compared to rural, 40.7% in the urban and 33% in the rural areas. According to the recent National Non-Communicable Disease Monitoring Survey, out of the total hypertensive patients, only 27% are aware that they have hypertension, 14% are among these 27, 14 are on treatment, and 12% were controlled. In India, it is directly responsible for all stroke deaths, about 57%, and 24% of coronary heart disease related deaths. Next slide. This persistent hypertension leads to HMOD and cardiovascular disease. In the eye, what it will cause is a microvascular remodeling and retinopathy. Heart, it will cause left ventricular hypertrophy, concentric, and because of that, there may be regurgitation and LA may be dilated. Atrial fibrillation, obstructed obstructive and non-obstructive coronary artery disease. High hypertension can itself cause acute myocardial infarction, and there may be some amount of diastolic dysfunction. Kidney, we see hypertensive kidney disease, like they will be go for renal failure, glomerular arterial hypertension, glomerulosclerosis, and decreased EGFR and albuminuria. Brain, predominantly there will be bleeding, that is hemorrhage. Second thing is ischemic stroke and silent microinfarct and all those things. Large and medium sized arteries, atherosclerosis, calcification, and arterial stiffness. Among these, the microcirculation, there will be endothelial dysfunction, stiffness of the arteries, increased vasoreactivity, vascular remodeling, fibrosis, inflammation, peripheral vascular resistance is increased. Next slide. Why combination therapy in hypertension? Because patients not controlled on monotherapy can be managed by increasing the dose of monotherapy, uh, along with associated with increased risk of side effects, or use drug combinations with reduced risk of side effects. Mechanisms causing blood pressure increase in patients are diverse. Monotherapy adhesiveness is one, and combination therapy allows for action on different hypertensive mechanisms. Next slide. Effective hypertension control with initial combination therapy, monotherapy and combination therapy control over the period of first years. This study was done, and median time of 50% patients achieving BP control was single pill combination was a 95% confidence interval. For free dose combination, again 95%. The third, for monotherapy, it was 280 days. It was also 95% number needed to treat was 273. Next slide. CV benefits of calcium channel blockers like amlodipine. Amlodipine is coronary artery and reduces the coronary artery disease, and it normalizes the blood pressure. Yeah. Primary efficacy endpoints was incidence of cardiovascular events for amlodipine versus placebo. It reduces the coronary revascularization and hospitalization from angina. Next slide. Cardiovascular outcomes accomplished study. Amlodipine or benazepril or amlodipine versus benazepril plus hydrochlorothiazide for hypertension in high-risk patients. Primary endpoint, time to first event, which was defined as a composite of CV event and death from cardiovascular disease. CV event significantly reduced by 20% either with combination of benazepril or amlodipine arm than benazepril and hydrochlor. That is diuretic arm. So definitely calcium channel blockers have shown significant benefit in reducing the cardiovascular events. Next slide. All those things are the same. Tell me, coming to ARB, telmisartan, there is a year and year we are aware that it is having nephroprotection. Next slide. These are three studies. Telmisartan is not inferior to enalapril in providing long-term renal protection in patients with diabetes. Similarly, in Vivaldi study, similar proteinuria reduction by about 30%. And Amedio study, albumin to creatine ratio reduction significant better with telmisartan versus losartan. Next slide. Next slide. Yeah, the prospective open-label randomized multicentric post-marketing study comparing effectiveness and safety of telmisartan. ಈತ ಕೇಳಿ ಏನು ಅವನಿಗೆ amlodipine, telmisartan plus cilindipine in subject with hypertension and renal impairment, investigational product. So study centers were 6 and 188 subjects were studied. Next slide. Study objectives for a primary and secondary objectives were defined to evaluate the compare the effect of telmisartan plus amlodipine versus telmisartan plus cilindipine on renal parameters. Secondary objective was safety of telmisartan and amlodipine and telmisartan plus cilindipine was hypertension and renal impairment. Next slide. Next slide. No, go back to conclusion. 2 slides before this. One more slide. So both telmisartan and amlodipine and telmisartan plus cilindipine were effective and well tolerated in treatment of hypertension and renal impairment. Telmisartan plus amlodipine may provide better BP reduction and similar renoproductive benefit compared to. So basically both are same. Next slide. Summary. Early and intense blood pressure control is crucial in improving outcomes in hypertensive patients. Dual combination of RAS inhibitors plus CCB may be initiated as the first line therapy. Pivotal trials like Cameliot study accomplished ALAHAT study showed the benefits of combinations of ARB plus CCB in cardiovascular protection. Innovation and other studies also showed the benefits of combination ARB in nephroprotection. So basically they have cardiovascular protection, they have kidney protection. So therefore telmisartan plus amlodipine combination provide tighter BP control over the 24 hours. Thank you.
Thank you, sir. Thank you for summarizing it really well. I do not see any questions in the chat box. So I would like to thank you and all the attendees who have attended this session and making it a successful one from the House of Glenmark and Telma Embrand. Thank you, sir. Have a good day.
Thank you. Good day.
Tech team, you can end the session.
Hello.
You can end the session, sir.